Good morning. I'm so happy to see you. We're going to get started. Wow, that was really great. Boy, the level, perfect. Welcome to the Sarah Health Foundation and to the So Simple, So Hard, Taking Medication as Directed. I'm Liz Helms, President and CEO of the California Chronic Care Coalition. Many of you I saw 2 weeks ago when we had our summit on comprehensive medication therapy management. So this is a perfect inroad. We work very closely with Script Your Future, working on public policy, on data, on research, all that information, which is so important to us as we move forward to really change the direction and improve quality and outcomes for people with chronic disease that take medicine, which there's many that take medicine, and we need to make sure that they're taking it correctly, that it's appropriate, and that they can adhere to the programs that are given to them by their doctors and their pharmacists. So welcome again. We're starting out with a very impactful day. There's a lot that's going to be taking place today. The Chronic Care Coalition has been working very hard with different agencies, especially with the Department of Public Health and Department of Health Care, on getting the clinical pharmacist on the care team, medication therapy management, comprehensive medication management, and adherence. And we have on October 21st, I believe, at the state capitol, we're going to have a briefing on this where we're going to be talking about both CMM and adherence at the same time. And we're in partnership with Script Your Future. So we're really happy about that. So how do you create a broad-based performance measures, and how do you relate the problems to non-adherence and measuring the severity? And then how do you stimulate appropriate interventions to treat the causes? We know that there are many barriers to care, and we are working and striving very hard to ensure that we are going to fix that problem so the whole team is put in place, and we have medication therapy management and the whole access to medicines appropriate and appropriate use. We know that adverse reactions happen. I have a personal story. About 3 years ago, I was taking some medicines that were contraindicating, and I was taking them correctly, probably taking one too much, and my doctor had prescribed this to me. He knew that there was a contraindication, but he never said to me there was a contraindication, and I ended up with stroke-like symptoms, lost the vision in my eye, had an ocular hole, was admitted 3 times to the hospital. Finally, after 6 months, I had a pharmacist that said, "Oh, are you having any problems?" And then all the light bulbs went on. I said, "Oh my God, this is crazy. Yes, I've been having problems." And then I actually sat down with the pharmacist and the team that we've put together that meets every month. And I said, "Would you guys look this up?" And that's called our Teaming Up group, which is working on all these policy issues. And they said, "Oh yeah, it's like number one alert." It was a number one alert. When I asked for help, and I said, "Can I get an appointment with my pharmacist to go over my meds?" They said, "No, it's not covered. It's not a covered benefit. We're not going to pay for it." And so that, when you're a policy person, you're an advocate, all of a sudden you're like, "Oh, wait a minute, something's really wrong with this picture. We need to fix this. We need to fix it quickly." People are leaving hospitals and not being adherent to their meds because they don't really know sometimes what they're taking or how they mix them together with what they had at home. There's so much work that needs to be done, and so I'm really glad that we're here today meeting to have these very difficult discussions and looking at the challenges and the solutions to all of this. I know the research and the data for us is extremely important. We need that as we move public policy forward, and by next year we will have public policy that we'll be working on. So I want to thank all of you for coming today. I want to also talk about affordability, because people can't adhere to their meds if they can't afford to get them. I'm hearing some new interesting stories that are going on. I was just talking to someone about diabetes meds that have been very affordable, and all of a sudden they're not affordable. And we've been working on one of our bills is headed to the governor right now. Several bills, all of our bills that we worked on this year are heading to the governor, but one in particular, AB 339, which is about specialty meds and capping the copays. But what I'm also hearing is, and what we need to hear from you also, are issues that are happening out in your areas. Are people having trouble affording their meds in a different way than what we've seen before? Because many times some of these medicines have been on tier 1, have the lowest copay, and all of a sudden they're being shifted to another tier. That will stop under 339. You won't be able to move tiers down or move tiers back to higher levels, but we don't have that yet. And so while we're working on that, we need to have those facts and know what's happening out there, because if people can't afford them, they can't take them. They won't take them. You know, at the end of the month when they're running out of funding and they're making decisions between food and taking their meds are going to go. And maybe they're going to end up in the hospital from that, and that's unacceptable. So we really want to work hard at fixing all of this and working together, and people in this room could help that happen today. So I want to welcome you again, and thank you so much for coming. I have the pleasure right now of introducing Rebecca Burkholder. She's Vice President of Health Policy at the National Consumers League. Ms. Burkholder coordinates the league's work on healthcare issues, including safe use of medicine, patient safety, doctor-patient communication. That's huge, we know. Getting pharmacy and physicians working together as a team. Directed to consumer advertising. She's also coordinated the Script Your Future campaign, so I'm very honored and happy to introduce.
Thank you, Liz, and thanks again for all of you for coming today. I know many of you are from nearby, but some of you I know made the trip from the East Coast, so thank you for coming to Sacramento for this conference today. Before we get started, there are several organizations and people I would like to thank. First, thanks to the Sierra Health Foundation for providing this great venue. We're hoping it doesn't rain because I think we're going to be able to eat outside. And thanks to our sponsors for making today possible. This conference would not be possible without the support of the Agency for Healthcare Research and Quality. AHRQ provided funding for us through their conference grant program, and we appreciate the agency's support. We also thank our additional sponsors, the California Endowment, the Congress of California Seniors, California Society of Health Systems Pharmacists, and HealthNet. And of course, much planning went into this conference. We started planning about a year ago, and I want to especially thank the Conference Planning Committee. They are listed on the back of your agenda, and thanks to their persistence and assistance in bringing this meeting to fruition. And of course, thanks to Elaine Lynn, our coordinator at Script Your Future. Many of you know her, and she did an excellent job of on the ground organizing this conference, everything from securing speakers to making sure we had coffee. So thank you very much, Elaine. So what should you expect today? This conference is really focused on you. So whether you are a researcher, a consumer patient advocate, a healthcare professional, a community health worker, a government agency worker, an industry representative, policymaker, this conference really is about you and engaging you in this issue of medication adherence. Because poor medication adherence really is a multifactorial problem, it's going to take a multidisciplinary response from all of us who interact and support patients. So our goal today is to really give you research findings, tools, and strategies that you can use in your organizations and in your practices to improve adherence and health outcomes, especially among underserved populations. As you can see from the agenda today that's in your folder, we have a full day, starting off in the morning with presentations on adherence research and health disparities, and then moving on in the afternoon to looking at a variety of strategies and tools to improve adherence that we hope you'll be able to utilize. One of the most important aspects of the conference today is to make sure you're interacting with your fellow conference attendees, to provide a forum for all of you to connect and lay groundwork for possible collaboration opportunities and initiatives to improve adherence. And we have set aside time today to make sure that happens in the table group discussions that are happening in the morning and in the afternoon and during our networking luncheon. So, make sure you take advantage of those opportunities. And to start off, I want to tell you a little bit more about the Scripture Future campaign. At NCL, we really view poor medication adherence with its severe health impacts on individuals as a public health problem. So since 2001, we've been leading the Scripture Future campaign, which is a public education campaign to raise the importance of medication adherence, specifically focused on patients with chronic conditions, their healthcare professionals, and of course their family caregivers as well. We brought together more than 135 stakeholder organizations to work together as partners in Scripture Future. This slide shows some of our national partners, but many of the local partners right here in California as well. The campaign aims to help people with chronic conditions to manage their medications by providing tools and resources to do that. We reach people through our website, scripturefuture.org, which offers interactive videos and tools to download. And one of the things from the beginning of our campaign was to not recreate the wheel. There's actually a lot of resources out there on adherence, but to bring them to one place where patients can access them. So with the help of our partners, we vetted tools, and they're available on our website. We also reach people through hundreds of local events where we provide medication counseling, traditional and social media, public service announcements, educational programs by our stakeholders, policy forums, and more. And as this slide shows, we do have some resources. We have posters, handouts, and our very popular wallet card that probably many of you are familiar with. We've disseminated over 1 million of these across the country and around the world, and it's now available in 5 languages, including Vietnamese, Hmong, and Chinese. If you're interested in materials, there is a material order form in your packet, so please let us know or contact Elaine or myself as well. In addition to national outreach, I should just move forward, right? Whoops. I did something wrong already with the technology, excuse me. So in addition to national outreach, the campaign has organized activities in 6 pilot cities. There we go. In 6 pilot cities, as you can see in this map: Baltimore, Birmingham, Cincinnati, Raleigh, Providence, and right here in Sacramento. And since 2011, each city has had a paid field organizer where we've built out local coalitions made up of local organizations. We are pleased that in the past year, all 6 of these pilot city organizations have evolved into statewide initiatives, and they have become self-sustaining, with many integrating into local organizations. Here in Sacramento, of course, we have Elaine Lynn, who's been the organizer, and she's developed a very robust coalition I know many of you are part of. That's made up of statewide local organizations, public officials, and agencies, and the activities are really a blend of grassroots education with policy involvement. In fact, as Liz mentioned, next month on October 21st, there will be this event in partnership with the Coalition and the California Pharmacists Association to conduct a briefing for legislative and executive branch on comprehensive medication management and adherence. We are also pleased to announce that the Congress of California Seniors will be our new administrative partner in California as Scripture Future continues work to improve adherence for all generations. So again, please see Elaine if you have any questions about our activities here in California and Sacramento. So through activities and events such as those held here in California, we have reached millions through the Scripture Future campaign, as this slide shows. Over 1,000 local events held. We've counseled directly 60,000 patients and introduced the campaign to over 50,000 healthcare professionals, with an estimated 12 million consumers interacting with the Scripture Future campaign. So what about impact? Does all this outreach make a difference? We've been evaluating the campaign from the beginning, and we measure impact in several ways. One is by surveys. We conducted a baseline survey before the campaign launched in our 6 pilot cities, and we also replicated that survey in 2013 and are replicating it again in 2015. The results are coming in right now. This slide shows the results of the 2013 survey. And we did find that there's this increase of patients believing that they're managing their medications better. And also we're seeing an increase in communication, and this is from patient perspective, which we think is really key in this adherence issue. In addition to patient surveys, we survey our coalition members, we track outreach, and survey those who attend events as well. And this afternoon, you'll be hearing about a project evaluating our campaign messages as well. We've also been collecting stories from patients across the country about the struggles they have managing their chronic conditions and medications and how they've been impacted by the Script Your Future campaign. And this slide highlights some stories from patients right here in Sacramento, in Cincinnati, and a pharmacist student in Baltimore. These stories are important, we believe, because they put a human face on this issue, and while highlighting what we already know, that adherence issue is complex. It is not so simple. As you will hear about more today, patients face many obstacles for making sure they have the appropriate diagnosis and the appropriate medication, to getting the medication, to refilling the medication, to taking the medication, and more. As we explore this issue today, it's really essential we keep the patient at the center of the discussion. When we were developing this campaign and talking to patients across the country and holding focus groups, we learned that one thing that motivated patients was for them to think about why it was important for them to manage their condition and to stay healthy, whether it was able to spend time with a loved one, to take a trip, to walk to the park, to play in a band, whatever that may be. The theme of our campaign is really based on personalizing those goals of therapy and linking the consequences of not taking medication to losing out on those important things that you enjoy in life. Thus, we encourage patients, and really all of you, to take the I Will pledge. You can read more about the campaign and some of the connections we've had with patients and with partners in the report that is in your packet as well. So what can you do today with this conference? You can engage, so there's be opportunity for that, so please engage with the people around you and ask questions of the speakers. You can disseminate conference information. This conference is being recorded, and the video recording will be made available along with the conference presentations in a few weeks. Think about others who may be interested in this conference information, and we'll also be writing up a report which will feature tools and resources, and we'd love for you to share that. Evaluation, this is really important to us. As part of our AHRQ grant, we need to be evaluating our conference, which is always a good thing to do. So please take the time to fill this out today. If you can't spend the whole day with us, just please fill it out and give it to Elaine or turn it in at the registration desk. We will also be surveying all of you again through email in about a month to find out, how you've used conference information. So please remember to do this, and to really make these evaluations attractive, we are going to be holding a raffle when you turn in your conference evaluation for Starbucks gift cards, so keep that in mind, please. And then also feel free to tweet during the conference, and you see the information up here about how you can do that. So now we're going to turn to our first panel of the day. So if the first panelist could come up here, please. Just take a seat here, bring your tent card, and I will be introducing all of you. And our first panel is going to be focusing on adherence research, and I think it will give us a good foundation for the rest of the day. We are pleased to have this panel of researchers with us who will be sharing with us about effective interventions, identifying barriers, and gaps in research as well. I will be introducing all three of the panelists. They'll proceed with their presentations, and then at the end, when all three are done talking, we'll have time for question and answers. So please keep track of your questions. And I'll be introducing the panelists and several speakers throughout the day. Do remember that there are complete bios in your packet if you want more information about them. So first, Dr. Leah Zulik, who is Assistant Professor of Medicine at Duke University Medical Center. She's also an investigator at the Durham Veterans Affairs Medical Center. And she will start off the panel with a general overview of adherence research. And then following her will be Dr. Kirby Lee, who is Associate Professor of Clinical Pharmacy at University of California, San Francisco School of Pharmacy. And Kirby's presentation will really focus on measuring adherence, interventions, and the use of technology. And wrapping up the panel will be Dr. Peter Kaufman, who will focus on interventions and health disparities. Peter is Deputy Chief of the Clinical Applications and Prevention Branch in Cardiovascular Disease at the National Heart, Lung, and Blood Institute with the National Institutes of Health. So thank you very much, panelists, for joining us today, and we'll let you start off, Leah, with the presentation.
Hi, everyone. My name is Leah Zulik, and as Rebecca kindly said, I'm an Assistant Professor of Medicine at Duke in Internal Medicine, and I'm delighted to be with you today. We are to report our disclosures, so I have research funding from the VA and Duke, but no conflicts of interest to disclose. And the resources that the National Consumers League have assembled as part of their Script Your Future campaign are dynamic. And I'm really pleased to start off our time together today, so thanks for having me. The statistics are staggering. 4 out of every 5 American adults takes at least 1 medication per week, and a quarter take 5 or more medications. The World Health Organization estimates that adherence to medications for chronic illnesses in developed countries like the US is about 50%. And for you all who have been in the field a while, I'm sure that you know this figure has been consistent for many years. This has major health implications and cost implications as well. Medication non-adherence leads to unnecessary disease progression. We've heard about unnecessary hospitalizations and avoidable costs, sometimes even death. And this costs about $318 billion each year, so this is a sizable sum. And I know that given the level of expertise and commitment in this room, we're really preaching to the choir to some extent, but I think it's important to just talk about the extent of this problem. And I'd like for us to take a few minutes to reflect on the triple aim of appropriate medication adherence. So appropriate medication use can clearly improve the health of the individual that's taking the medication through addressing their specific health needs, through better disease control and symptom management. We can also provide better health care. Addressing adherence is critical for the delivery of safe and effective health care, and it's increasingly tied to reimbursement for services as well. And appropriate medication use can improve population health, and this is really where the Script Your Future campaign is stepping in. We do this through improving individuals' health and improving health care, as well as making policy-level changes, like lowering drug prices and changes to healthcare reimbursement. And when we successfully meet these triple aims, we have more efficient use of resources. We also have the professional and hopefully personal satisfaction for doing the right thing, possibly as well as financial rewards for doing so. But when we talk about non-adherence, I think it's important to really assess that we're on the same page. Are we all talking about the same thing? So later this afternoon, we'll be hearing more about how we can assess and measure medication adherence. We have many evidence-based metrics to measure adherence, and they typically categorize it as a binary measure. So you're either adherent or you're non-adherent. While this is helpful for many applications, it's important to understand that in real life, medication adherence really is not a black or white issue. It occurs on a continuum. And along this continuum, we have different processes and sets of behavior. And as a result, we have different ways to define and think about medication adherence. So when a patient is first given a new medication, they have to get that prescription filled. That's our first opportunity for failure. And failure to ever fill that prescription is called primary non-adherence. This is quite common. About 30 to 35% of prescriptions are never filled. And next, we have problems faced by patients who are continuing to take their medications over time. Here, we could have problems with failing to refill a prescription, refilling it, but filling it too late, or not taking the medication properly. This is secondary non-adherence, and this is also quite common. Again, about half of medication failures occur here. And we also might have a situation where a patient stops taking their medication entirely. We call this discontinuation. And this entire span of process from when a patient initiates a drug to when they stop taking it is called persistence. Now, measuring discontinuation when a patient stops taking their drug can be challenging. How do we know, for example, if a clinician has verbally told their patient to stop taking their meds or if the patient has just decided to do it on their own? If it's the latter, how do we know whether the patient has intentionally decided to stop taking a medication or if they're doing so because they can't tolerate side effects or because the copays are too expensive for them? We need to think about whether this is unintentional discontinuation. Also, perhaps the patient is having trouble remembering to take their medications, forgetfulness. And so the strategies that we would choose to use would vary and differ depending on the reasons that are underlying the problem with medication taking. So when we measure adherence, what we see is really just the tip of the iceberg. There are a host of other contributing factors at play. Things like lack of information, poor communication, disengagement in self-management, complex drug regimens, financial and cognitive constraints, and mismatched values and preferences, among others. So I'd like for us to just think a minute about a hypothetical patient, Mrs. Smith. So let's say Mrs. Smith is a 66-year-old woman. She has health insurance and she can generally afford to pay for her prescription co-payments. She's retired, so in theory she has time to manage her care. She doesn't have any issues with cognition, and she has the ability, essentially, to engage in her health care. Mrs. Smith is taking 5 medications each day. She doesn't really know why she's taking them or what they're for, and she's afraid to ask her doctor for help because she doesn't want to seem like she's uninformed, and he's always very busy. Mrs. Smith does have a daughter who lives down the street and is willing to help her take her medications properly, but the daughter feels that her mom really isn't that motivated to get control of her health. So what we have here are a list of pretty typical patient-related factors that can be barriers to medication adherence. And when selecting the best way to intervene to help Mrs. Smith improve her health care, we need to really target our solutions to her specific needs. And it's important to remember that this doesn't occur within a vacuum. We need to engage not only Mrs. Smith, but also her family and her caregivers as well. So it may sound as though Mrs. Smith and her daughter have a very difficult job to remain adherent, and they certainly do. But her clinician's role is also equally complex. So there's a long list of things that clinical care teams can do that we know will work. However, a primary care provider alone may not be able to realistically educate Mrs. Smith about the cost of her medications, which are going to be variable depending on the insurance of the patient, link her with financial assistance if needed, communicate with her pharmacist about refills, and educate her on how to take the medications properly, possible side effects, and so on, all within the context of a 7-minute clinical visit while also addressing the need to lose weight and a host of other things. And that's why medication adherence really needs to be a team sport. Appropriate medication use necessitates good communication between all of these stakeholders, the patient, their family members and caregivers, community pharmacists, and others. And even when we have good communication, we still need evidence-based tools to help us improve our adherence, and we'll be hearing more about those later today. So we have many interventions that we know work. So the question really begins, can we develop a toolbox from which to select these interventions? And there have been several systematic reviews and meta-analyses searching for effective evidence-based interventions. One exemplar review was conducted by AHRQ, and from these studies we know that effective interventions generally hold to several key principles. So first, we generally see only modest effect sizes for adherence improvement, but that can still be significant on a population level if they also lead to improvements in clinical outcomes, and that's quite important. It's not enough to just improve adherence. We need to actually impact patients' health. And second, adherence is a process. The health outcome, like blood pressure control or change in A1C, needs to be the endpoint. There is no one-size-fits-all intervention, and Rebecca alluded to this in her opener this morning. We need different tools for different populations, contexts, and conditions. We know that combinations of 2 or more intervention strategies across different dimensions tend to work best. We talked about how medication adherence is a complex issue, and so it's logical then that our solutions need to also be complex and include multiple strategies. I'll talk more specifically about this in a few slides. In general, there's a low to moderate strength of evidence for most of our work. And that is because there are some substantial limitations with some of our existing research findings. Studies are often designed with too small of a sample or too short of an intervention, or they don't have long-term follow-up data. They're often poorly conducted regarding fidelity, or more commonly, they just aren't reported in sufficient detail that we actually know how to replicate them in a clinical setting. Because many of our studies begin as highly controlled clinical trials, it can be difficult to generalize to other populations. For example, we often only study one disease group when in reality our patients have multiple chronic conditions. So in short, our research interventions are often complex, and they may need to be, but they could be difficult to implement in real life. So now I'd like to focus on some of the positive, specifically these combination interventions that we know work. Interventions are most effective at improving long-term adherence when they address these multiple dimensions of education, motivational and behavioral domains, and system-level change. Specific examples of behavioral interventions include things like self-management and phone or emailed reminders. And system-level interventions often include things like case management, care coordination. Those have been particularly